Okay, here we go. Continuation of chapter 12, the first part.
Wait, almost was
The
right.
first part was cut off, but there'll be two links for chapter 12. All right. So as we were talking, performing the primary assessment, when we perform the primary assessment, the way we approach the patient, okay, the approach to the patient determine if the patient appears lifeless or if the patient has signs of life. So it's all going to depend on how we see the patient. If we look on 285, we check for, on that schematic there, we look at the check for responsiveness, perform a quick scan of the chest and breathing, and there we determine if the patient's high priority or what we're going to do next. Okay, so we form a general impression, we assess the patient's mental status, we assess the patient's airway, breathing, and circulation, and the priority. Okay, core concept on page 284, manual stabilization of the head and neck when necessary. So if we suspect the patient has trauma, we do manual stabilization of the patient's head and neck if we suspect a spinal injury. Okay, so to form a general impression basically is the patient's condition that is formed on first approaching the patient based on the patient's environment, chief complaint, and appearance. How does the patient look? They look sick or not sick? They look critical or stable is what we're going to determine. And if we look on 285, we look at that little girl in figure 12-2. Forming a general impression includes your immediate assessment. So the immediate assessment is we see that this patient, or this child was skating, she fell, she scraped her knee, and she hit her head. So is that a high priority? No, that's not a high priority. She's alert, she's awake, so she's got airway, breathing, circulation that are intact. The next page on 286 and 287 talks about the steps that you're going to take. After we form the general impression and we determine the priority, now keep in mind that whenever you see an unconscious patient, it's a high priority automatically, even before you identify that the patient has an open airway and is breathing or in circulation. Unconscious patients are all high priority patients. Okay. Then on the airway, we open the airway, we insert any airway adjuncts as needed. If the patient's not breathing, we can use it on oropharyngeal airway, nasopharyngeal airway. We assess breathing. If they are breathing but they're struggling to breathe, we may use a nasal cannula or a non-rebreather mask. Or if the patient is not breathing, we may use the airway adjunct with the back valve mask as well. So when we're using a back valve mask, how many liters of O2 do we put that at? How many? 15 liters per minute. A back valve mask is set at 15 liters per minute. A nasal cannula is set at 1 to 6 liters per minute, and a non-rebreather at 10 to 15 liters per minute. Now they will all give you a certain amount of concentration of oxygen, as we talked about in the previous chapters. Okay, when we're assessing circulation, we're assessing pulses, whether it's the carotid pulse or the radial pulse or the brachial pulse. We're also, if the patient does not have a pulse, we're doing chest compressions. If the patient has active bleeding, then we're applying tourniquets or we're applying direct pressure, as we see there on page 287. Okay, manual stabilization on scan 12-1 on page 288. We see that during the primary assessment, we do C-spine ABC simultaneously. So the National Registry may ask you a question on which should you do first, ABCs or C-spine. Well, the answer is C-spine because you do C-spine ABCs at the same time, okay? But it'll be C-spine that would come first, that manual stabilization. So the look test. The look test on page 288, how does the patient appear? Do they appear lifeless? Do they appear moving? Okay. Patients who have an obvious altered mental status, who are unconscious or unresponsive. Patients who appear unusually anxious and those who appear pale. Obvious trauma. Okay, and specific positions indicate distress. What position indicates distress or respiratory distress? Which is, what is that called? Tripod position tells us that the patient's struggling to breathe. What is the chief complaint?
The reason why you got.
The reason why they called, right? The reason, what their reason for calling EMS. All right. So if we look on page 290 in figure 12-3, we see that little girl that's in the tripod position. That automatically tells us that the patient's struggling to breathe. And also if the patient is speaking in 2 to 3 word sentences, also tells us that the patient is struggling to breathe. On figure 12-4, we see the patient showing Levine sign. Levine sign is the fist to the chest. That's telling me that the patient's having some type of chest pain. It could be possible myocardial infarction or a heart attack, right? So when we're assessing mental status, we use a mnemonic called AVPU. AVPU is a mnemonic to assess mental status, and that stands for alert, verbal, painful, and unresponsive. Are they alert as you approach them? Or let's say they're unresponsive and you speak to them and they wake up and they open their eyes to your voice, then they're alert to verbal response. Or they don't respond until you touch them or shake them, then they're alert to painful response. Now, if they don't respond to your voice or to your touch, then they're considered unresponsive in the AVPU scale, the U in the AVPU scale. So that's a mnemonic that you do have to know is AVPU, alert, verbal, painful, and unresponsive, and that is a method to determine altered mental status, okay? And we're assessing airway ABCs, airway, breathing, and circulation. So let's look at page 281 in the section of breathing or airway. Airway, we determine if it's clear or obstructed, okay? Patent or not patent. Breathing, we assess the patient's effort of breathing. If the patient is in respiratory arrest with a pulse, perform rescue breathing. If the patient is not alert and his breathing is inadequate, okay, with an insufficient minute volume because of decreased rate or depth, provide positive pressure ventilation. So when we're assessing breathing, it's either they're breathing or not, okay? If they're breathing, then we got to determine if they're struggling to breathe. If they're struggling to breathe, then we give them oxygen non-rebreather mask 15 liters per minute or nasal cannula, depending on how severe their respiratory distress is. And if they're not breathing, we use an airway adjunct and a BVM for positive pressure ventilation. It's real simple, breathing or not breathing, okay? If they're not breathing, BVM. If they're breathing, an oxygen delivery device, okay? So real easy to assess breathing. On figure 12-5, it gives you there a little schematic of how to approach the patient and how to assess breathing and which route to take. On page 293, we see where they find a patient unresponsive, okay? They enter the living room, they're unresponsive. Now they're assessing, if you notice that they assess circulation. Now let me tell you the difference between ABCs and CAB. On a stable patient, we assess ABCs. On a critical patient, unresponsive patient, we say CAB, circulation, airway, and breathing, okay? Stable patient, we assess airway, breathing, and circulation. Unstable patient, unresponsive patient, we assess circulation, airway, and breathing. A little bit backwards, but that's how it is. All right, and number 3, they've assessed pulse, there's no pulse, they're doing CPR, they're attaching the AED, and they're using positive pressure ventilation for that patient in 293. The next, on 294, we see a page where EMTs and firefighters enter the room, okay, with a checkered floor, and there's a ladder, so the patient probably fell. That's what we're going to suspect. The patient is unresponsive. Because we see the ladder, we suspect that the patient fell. Then what they do is, the first thing that they do at the same time they're doing ABCs is holding manual stabilization of the head or C-spine. Okay, so C-spine, open the airway, C-spine, ABCs, okay? If the patient has fluid secretions or in the airway, then we're gonna suction the airway with our suction machine, all right? And then we can insert an oral pharyngeal airway or nasal pharyngeal airway. We use an airway adjunct, okay? Here on number 5 on page 294, evaluate breathing for rate and depth. He has his hands on the patient's chest to check for symmetrical chest rise and fall. Symmetrical chest rise and fall. That tells me symmetrical means even rise and fall. Okay. On number 6, they're doing positive pressure ventilation. On the next page on 294 on scan 12-13, during the primary assessment with a patient that has a pulse, okay, this patient with a pulse, they apply a non-rebreather mask because the patient's breathing, okay? If the patient has any bleeding, they're going to control bleeding, okay? They're going to check radial pulses and skin color and temperature, as well as provide spinal mobilization and request ALS. Now, requesting ALS is basically advanced life support. That basically means that if there's an ambulance that has a higher level of care, advanced life support, then and they're nearby, then you can call them to meet you and they can take over patient to provide the advanced level care that would benefit the patient. All right, so determining priority. We already talked about circulation. Determining priority. Give me some examples of a high priority. Stab wound, chest, gunshot wound,
A head-on collision.
head-on collision with severe injuries, cardiac arrest, you know, and the list can go on and on. And, you know, if the injury is severe, then we're gonna consider it a high priority of the patient. How about low priority? You know, sometimes they call you for an earache, you know, or for a headache, you know, or just abdominal pain. Some abdominal pain can be high priority depending on their vital signs and all that. But, and sometimes it requires us to do more of an assessment to make that decision. If we cannot make the decision right away, then further assessment may help us make that decision. So, again, to be stable, a patient needs to have vital signs that are within normal range. A threat to the airway, breathing, or circulation automatically makes the patient a high priority patient. There are many times when it is not crystal clear when a patient's problem is so there will be many possible diagnoses, some more serious than others. And again, like I said, it requires more assessment. Now, the patient's priority can change. The patient can be stable at first and on the way to the hospital deteriorate, maybe have some internal bleeding or other complications, and then you would classify the patient as high priority. So you would upgrade. You're transporting with no lights and sirens, all of a sudden the patient gets more sick and more critical, then you advise your partner, hey partner, go ahead and let's go code 3, let's go high priority, let's turn on the lights and sirens, and let's get to the hospital a little bit faster, all right? So there on page 297, on table 12-1, it gives you a list of some high priority situations, and also the primary assessment steps and interventions on page 298. I'll let you read that on your own, and basically it's going to tell you what the condition that you have and what you're going to do in each of those conditions. All right. 299 gives you a scenario. I want you to read those scenarios and go through those ABCs and priority and make that decision as well. I'll let you read those scenarios on your own. Okay. All right. So that concludes chapter 12. Okay. Make sure that you read chapter 12. Make sure that you go over the key terms. And there may be some questions at the very end. There's some short answer questions also that will be helpful. So there's any questions on chapter 12? No, there's no questions on chapter 12. Then don't forget to go to our website, healthwebc.com. Thank you.